Is it streaming? Hi everyone, this is Dr. Mandeep and welcome to today's live stream. मैं कुछ लोगों के लिए वेट करना चाहूँगा ये लाइव स्ट्रीम स्टार्ट करने से पहले, तो थोड़ा बहुत बात करते हैं एंटीबायोटिक्स के बारे में। इन जनरल एंटीबायोटिक्स एक काफ़ी डिफ़िकल्ट टॉपिक है जो कि बच्चों के लिए मेमोराइज़ करना बड़ा मुश्किल है। इसको मैं डिस्कस इसलिए करना चाहता हूँ कि 30 मिनट्स में आप शॉर्टली कुछ चीज़ों को याद कर पाएँ, ईज़िली अंडरस्टैंड कर पाएँ कि हम एग्ज़ाम में और रियल लाइफ में एंटीबायोटिक्स को कैसे यूज़ कर सकते हैं। तो ये डिस्कशन उसी के बारे में रहेगा जो मैं ट्राई करूँगा। आई ट्राई टू कवर इट इन 30 मिनट्स सो दैट इट्स ईजी फॉर एवरीवन टू grasp small things, but they are going to make a big impact in the patient's life. Another thing, 11th अगस्त को नीट पीजी का एग्ज़ाम होने वाला है. I believe all of you are prepared and revising in the final days before the exam. डटे रहिए. मुश्किल टाइम तो रहता है सभी के लिए, पर जो भी मुश्किल को पार कर सकता है हिम्मत के साथ, साहस के साथ, they come out victorious towards the other end. Even if it doesn't come out to be as you expect it to be, learn from it, become better. That is all I want to say about NEET PG right now. We are currently joined by 6 people. जैसे मैं फ़ोन पे देख पा रहा हूँ. I'll wait for a few more. For the time being, let's talk about antibiotics in general. Antibiotics मेरे को personally it was very hard for me to memorize their names. तो pharmacology एक ऐसा subject है that involves a bit of memorization but also concepts. जब concepts याद हो जाते हैं तो जो memorization का part है वो भी easy हो जाता है. मेरे को अपनी बायोलॉजी टीचर का एक सेंटेंस याद है. शी यूज्ड टू से कि आप समझ लो पहले, नाम तो याद हो जाएंगे. तो वो प्रिंसिपल फॉलो करते करते ऑलमोस्ट काफ़ी साल हो गए मेडिसिन में. क्या कहते हैं, पेशेंट्स को ट्रीट करते, पढ़ते पढ़ाते टाइम निकल गया. तो वो प्रिंसिपल ने मेरे को हर जगह हेल्प करी. तो देयर इज़ अ चांस दैट इट माइट हेल्प यू. ट्राई इट and if it doesn't, we might be able to find something new, right? तो अभी एंटीबायोटिक्स के बारे में और बातें हैं कि एक तो चलो नाम की बात हो गई, दूसरा होगा कहाँ यूज़ करना है. एंटीबायोटिक्स का स्पेक्ट्रम एक बार देखना ज़रूरी रहता है जब भी हम कोई एंटीबायोटिक यूज़ करते हैं. तो अगर आपको स्पेक्ट्रम नहीं याद है तो वो थोड़ी मुश्किल की बात हो जाती है. एंड विद मेडिसिन इन जनरल जब एंटीबायोटिक्स भी यूज़ करते हैं, जितना प्रैक्टिस करेंगे, जितना पढ़ेंगे बार बार, उतना याद होगा आपको. कई एंटीबायोटिक स्पेसिफिकली और कुछ ऑर्गेनिजम्स के लिए यूज़ किया जाता है. जैसे कि सूडोमोनास के लिए कार्बापेनम एंटीबायोटिक्स यूज़ किए जाते हैं. दे आर अ पार्ट ऑफ बीटा लैक्टम एंटीबायोटिक्स. तो वो सूडोमोनास को कवर करने के लिए, ऑल्दो उनका स्पेक्ट्रम काफ़ी ब्रॉड है, पर जहाँ पे भी सस्पेशन रहती है सूडोमोनास की, वहाँ पे यूज़ करते हैं कार्बापेनम एंटीबायोटिक्स को. सिमिलरली सेफलोस्पोरिन्स की बात करें तो क्लासिफिकेशन तो सभी को मुश्किल लगती है. इम्पॉर्टेंट क्या है उसमें, इंडिविजुअली सेफलोस्पोरिन के नेम्स पता हों और उनको यूज़ कहाँ करते हैं. जो उसकी क्लासिफिकेशन भी है उसमें भी 3rd या 4th जनरेशन सेफलोस्पोरिन्स हैं. मोस्टली वही हॉस्पिटल सेटिंग में यूज़ किए जाते हैं. तो उनके बारे में याद करना है एक बार, सो दैट आपको क्लिनिकल एक्सपोजर से रिलेटेड एंटीबायोटिक यूज़ का भी पता चले, और you know what are the basics of cephalosporins, right? Currently we are joined by 10 people. Now I shall start. So let's start with, because antibiotics, what are antibiotics? They are drugs which are targeting certain organisms. mostly microorganisms. Now in microorganisms mostly we have the gram positive bacteria and the gram negative bacteria, and then you also have anaerobes. जो gram positive gram negative bacteria, that is depending upon certain स्ट्रक्चरल कैरेक्टरिस्टिक्स ऑफ दीज बैक्टीरिया, उस बेसिस पे इनको क्लासीफाई किया गया ग्राम पॉजिटिव ग्राम नेगेटिव में. और एनारोब्स क्या हैं, जिनको ऑक्सीजन की रिक्वायरमेंट ज़रूरत नहीं पड़ती, दे कैन सर्वाइव इन एब्सेंस ऑफ ऑक्सीजन, दैट आर कॉल्ड एनारोब्स. नाउ जो फर्स्ट क्लास ऑफ एंटीबायोटिक्स हम डिस्कस करेंगे, दीज आर सेल वॉल सिंथेसिस इनहिबिटर्स. इस फर्स्ट कैटेगरी में वी हैव नंबर ऑफ एंटीबायोटिक्स. ना अब हमें समझ लग गया कि सेल वॉल को टारगेट करेंगे ये एंटीबायोटिक्स. सो फर्स्ट ग्रुप इसके अंदर क्या आएगा, पेनिसिलिन ग्रुप. जो पेनिसिलिन एंटीबायोटिक्स हैं वो सेल वॉल सिंथेसिस इनहिबिटर्स हैं. उसके बाद यू हैव सेफेलोस्पोरिन्स. Then the third category is carbapenems. Then you have aminopenicillins. Then you have uridopenicillins. Then उसके बाद आते हैं मोनोबैक्टम्स. What is common amongst all of these? Common क्या है? They bind to penicillin binding proteins. They bind to penicillin binding proteins. And what are these penicillin binding proteins? These are transpeptidases. एक enzyme है which plays a role in the formation of peptidoglycan layer, which is present in both gram positive and gram negative bacteria. So once you destroy the peptidoglycan layer, you destroy the bacteria. So these are the cell wall synthesis inhibitors. And then you have protein synthesis inhibitors also. So when bacteria multiply, they need certain proteins in their environment to make up something new. Obviously their structure is made up of proteins also, because it's a mixture of proteins, lipids and carbohydrates. You need enzymes to do that. Now in protein synthesis inhibitors हमारे पास कुछ classes हैं. For example, macrolides. The macrolide antibiotics, they are protein synthesis inhibitors. And the second category is the tetracyclines. They are also protein synthesis inhibitors. So when you inhibit the protein synthesis in the bacterium, you are inhibiting their multiplication. और multiplication में भी you need a lot of enzymes to do, right? So ये तो दो broad categories of antibiotics हैं. Cell wall synthesis inhibitors and then protein synthesis inhibitors. Some of the antibiotics, they also impact the DNA. Or indirectly. For example, sulfonamide antibiotics, they inhibit certain steps of utilization of folic acid. And again there is a another antibiotic called trimethoprim, जो कि okay, um, sorry for the delay guys, there was some technical issues on our side. We'll I can see it on my so we shall continue with our discussion. Thank you for your patience with us. Let's concentrate on the penicillin antibiotics, the cell wall synthesis inhibitors. Now for the penicillin antibiotics, they have something common, a ring that is called a beta-lactam ring. This beta-lactam ring is present in all of the categories of the penicillin antibiotics. The penicillin antibiotics, whatsoever class was derived from the penicillins, they have the beta-lactam ring. So the prototype penicillins that we have here are penicillin G and penicillin V. They predominantly cover the gram-positive bacteria, and they do cover some spirochetal infections. Or the spirochetal organisms. If I say for specifically penicillin G, it is combined with a group benzathine, so that when it is injected into the body of the patient, the release is slow. So what it essentially does is कि जो drug release होती है after the injection, maybe an intramuscular injection, muscle में inject किया हमने एक antibiotic, and then because of the benzathine group it is released slowly into the concentration. इससे क्या होगा कि the amount of time for which the penicillin is present in the circulation will prolong, and it will treat the underlying condition. Now what are the specific indications for this? As I told you, these penicillins, the prototype penicillins, they are primarily active against gram-positive organisms and these spirochetal infections. For the gram-positive, especially if you have a patient with rheumatic fever or someone with syphilis, they are treated with the penicillin group. Now for syphilis it is the treatment, while for the rheumatic fever it is the prophylaxis. And what do I mean when I say prophylaxis? In prophylaxis you prevent something. You prevent something from happening. In case of rheumatic fever, there is a complication, that is carditis, that leads to formation of mitral stenosis, aortic stenosis, and most commonly it is the mitral valve that is involved after rheumatic fever. And because it is secondary to streptococcal infection, Because it is because of streptococcal infection. Giving prophylaxis prevents the complications of rheumatic fever. Streptococcal infection, it initiates an immune response, and that produces antibodies and immune cells. Those immune cells and the antibodies, they attack the heart and lead to inflammation, that is known as carditis in case of rheumatic fever. Now, for the second one, syphilis. Syphilis is a sexually transmitted infection, and syphilis, it is an infection whose antibiotic of choice is benzothine penicillin G. And even in case of pregnancy, if someone who's allergic to penicillin and they have syphilis, you need to treat them with penicillin despite the allergy, because there is no effective treatment other than penicillin for pregnancy related syphilis. You need to treat the pregnant patient. And how do you do that? The patient is allergic to that. You do penicillin desensitization for the pregnant patient who has syphilis, right? So that is about penicillin G and penicillin V. Let's talk about another group of cell wall synthesis inhibitors, the cephalosporins particularly. Why am I concentrating on certain groups? It is because they are frequently tested in the exam. Secondly, they are important in the clinics as well as the hospitals. For the cephalosporins, we shall concentrate on the third generation cephalosporins. I won't go into the full classification of cephalosporins. Why? Because it is difficult to memorize. Let's concentrate on a single group so that it is easier for us to remember. Now, for the third generation, there are certain cephalosporins. The names are ceftriaxone, and then you have ceftazidime. The third one is cefoperazone, and the last one is cefotaxime. Now, for these third generation cephalosporins, they are frequently combined with other antibiotics. And if I talk about those conditions, one is pneumonia, other is meningitis. And why these two? For both of these infections, the common organism is Streptococcus pneumoniae, and they can also be due to gram-negative infections. And it is to be remembered that this third generation cephalosporin group covers gram-positive and the gram-negative organisms, right? So they have a very broad spectrum of coverage. Now, if I talk about ceftazidime in particular, this particular cephalosporin is active against Pseudomonas. While the others are not. This is one exception. And if you suspect the Pseudomonas infection, and where do you suspect Pseudomonas infection? If someone has an infection, either a pneumonia, UTI, within the hospital itself, maybe it was a hospital acquired infection. That is what I'm indicating. I won't be getting into the definition of hospital acquired infections. What I want you guys to remember that Pseudomonas is one of the organisms of hospitalized patients. Hospitalized patients, they frequently have urinary catheters in place, especially the old ones. And Pseudomonas is a gram-negative organism, and it can go into the urinary tract when you catheterize the patient. Then there are multiple levels to prevent that. That is a separate discussion, but I want you guys to remember that Pseudomonas is one of the organisms for hospital-acquired infections, and ceftazidime in the third generation cephalosporins covers it. Now going back to pneumonia and meningitis itself. Now for these two on infections, we have an empiric cover. We have an empiric cover. Now when I say empiric, that we presume that certain organisms are infecting the patient depending upon the most frequent ones, and that is what this cover is based upon. For both of them, we have a cephalosporin, right, covering gram positive and gram negative organisms. Now for pneumonia, there are certain atypical organisms. These atypical organisms are chlamydia, mycoplasma, and legionella. And these organisms, they can be targeted through use of macrolides or tetracyclines. So you can imagine the cover usually includes macrolides or the wait a minute, I'm really sorry. So you can use macrolides, not tetracyclines, macrolides or fluoroquinolones. So for the pneumonia itself, you can use macrolides or fluoroquinolones in combinations with cephalosporins. For the meningitis itself, there is another organism rather, which could be responsible. It could be Staph aureus. And we have Streptococcus pneumoniae also. Both are gram positive bacteria. And we want to cover gram negative also, and we do not want to give single antibiotic also. Now when you give two antibiotics combined, the capability of the bacteria to overcome either antibiotic is difficult. So if you give a single antibiotic, the possibility is that the resistance will be fast. So in case of meningitis, you have a cephalosporin combined with drug vancomycin. What is vancomycin? It's a glycopeptide antibiotic. It is also a cell wall synthesis inhibitor. The mechanism of action is a bit different from other cell wall synthesis inhibitors. It involves the inhibition of an enzyme called transglycosylase. We won't be talking about that, but what I want guys to remember that it's a glycopeptide combined with cephalosporins in the management of meningitis. And the cephalosporin in both of these cases is a third generation cephalosporin, and obviously the patient would be hospitalized patient, right? And the earlier generation of cephalosporins, they do not have very broad spectrum coverage. The third and fourth generation ones, they have a very broad spectrum coverage, and even they cover the resistant organisms to some extent, not all. So that is one case. Now for meningitis particularly, I want to add one more point. If the age is more than 50 for the patient with meningitis, listeria becomes also common. So in this cover with cephalosporin, vancomycin, you also add ampicillin. What is ampicillin? It's a extended spectrum penicillin. Now, the initial penicillin such as penicillin G, penicillin V, they have very narrow spectrum of coverage. They covered mostly gram-positive bacteria. For after that, as newer antibiotics were made, newer penicillins were made, the extent of their spectrum was extended, and that is when the antibiotics called extended spectrum penicillins came into picture. That is ampicillin and amoxicillin. Ampicillin and amoxicillin. So ampicillin particularly covers listeria. In case of meningitis, if age is more than 50. For pneumonia, you have empiric cover with cephalosporin plus macrolide or a fluoroquinolone. And for meningitis, it is cephalosporin with vancomycin. If age is more than 50, you can add ampicillin. Now that is all about the third generation cephalosporin and the discussion in relationship to pneumonia and meningitis. Let's talk a little bit about resistance. Now, all of these cell wall synthesis inhibitors, mostly the beta-lactam ones, they have a beta-lactam ring. So what these bacteria, they came up with a defense. They started to make an enzyme which broke down the beta-lactam ring. They were called beta-lactamases. These beta-lactamases, they destroyed the beta-lactam antibiotics. Now, as the scientists, they came to realize that the bacteria were producing certain enzymes, they came up with the inhibitors of beta-lactamases. So we have a class called beta-lactamase inhibitors. Here we have sulbactam, clavulunate, tazobactam, and then relebactam, and the last one is vaborbactam. One particular drug you guys must have encountered if you are living in India, it is frequently prescribed, augmentin. हम सभी ने ऑगमेंटिन अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शन में खाई है कभी ना कभी. तो व्हाट इज ऑगमेंटिन? इट इज अ कॉम्बिनेशन ऑफ अमोक्सिसिलिन with clavulunate. So I want to highlight that this clavulunate is a beta-lactamase inhibitor, and it is pretty common for bacteria nowadays to have the resistance to beta-lactam antibiotics, and it is growing. And why is it growing? It is because of irregular use of antibiotics everywhere. You need a guideline. You need a guideline to regulate these antibiotics so that the resistance doesn't develop. And what is the purpose of this lecture while teaching you certain groups of antibiotics and how the empiric covers work and what are the spectrums of these drugs? It is to sensitize you. यार antibiotics इस सिनेरियो में यहाँ ऐसे यूज़ करना है, इसके लिए इंडिकेटेड है, दिस इज़ द इंडिकेशन. यू डोंट नीड एंटीबायोटिक इन एवरी केस until unless you suspect a bacterial infection. And as you have more clinical experience, exposure to patients, you will realize that most of the patients that we get through seasonal changes of pharyngitis, even the infection of the middle ear, obviously it could be a bacterial infection of the middle ear also, but what I'm talking about is serious otitis media, where decongestants could work. But people have the habit of prescribing antibiotics, which is not so good, and that is leading to a lot of resistance. I believe this is all I wanted to teach you guys in this 30-minute discussion about antibiotics. We have another live tomorrow about pharyngitis with Dr. Bhanu. Join us again so that you can learn more, just like we did within just 30 minutes, right? I believe this was a great learning experience for all of you. We'll be back again with another live with me the next week, but stay tuned with us for the very next live tomorrow with Dr. Bhanu on pharyngitis. Goodbye.